So let me introduce to you Mark Butler. Mark is a physical therapist that has been in practice for over 25 years and is an adjunct professor, assistant professor at Rutgers University and guest lecturer at Stockton University. Mark completed his doctoral studies at Regis University in Denver. How'd you have any time to work? Okay, where he graduated with honors. Mark has taught over 150 weekend courses and has presented at more than 25 national and regional conferences. He authored the shoulder chapter in the textbook Fundamentals of Hand Therapy, Clinical Reasoning and Treatment Guidelines for Common Diagnosis of the Hand and Upper Extremity. He is published in peer-reviewed and non-peer-reviewed professional journals and is currently active in clinical research. He is fortunate to be honored as one of the therapists selected on an annual basis to receive the prestigious James Tucker Excellence in Clinical Practice and Teaching Award by the New Jersey chapter of the American Physical Therapy Association. Mark currently manages the Medford NovaCare, where he carries a full caseload. Now, that's the written part. Here's the non-written part. I've been in practice 39 years. I have never met a physical therapist who understands this disease and how to treat it better than Mark does. Okay? From my office, the referrals go to Mark because I don't have to tell him what to do or what not to do. And believe me when I tell you, I spend a lot of time telling physical therapists what not to do. Mark gets it. And as I said, he's the best I ever saw. And when I needed physical therapy, I was a very poor physical therapy patient. Guess where I went? Please welcome Mark Butler.
Thank you. I don't think, I have to sit down now. I can't top that. That's quite an introduction. So real quick, the topic I'm talking on today is an area of physical therapy and treatment for this most challenging disease that shows some promise. It might not be for everybody, but it might be for some or a lot of you, I don't know. What's my story with this? I heard about RSD when I was a student in the mid-'80s, and it immediately fascinated me that there could be a disease like this, that no one really knew what was going on. So I get into my own clinic, and these patients occasionally will come through my office, and I go, these are the ones we learned about in school. I didn't know what to do with them. I just like, And I was starting to figure out some things that seemed to work. And I had a particular patient who was suffering from a brachial plexus stretch injury. And I was getting a repertoire of being able to help these patients. And they were coming to me from all over the country, actually. And from Dr. Schwartzman. I never met Dr. Schwartzman. So one of my patients suggested I go over there and hang out with their office when Dr. Schwartzman was following patients. So I tagged along. He didn't know I was there. Those of you that saw Dr. Schwartzman know he would have an entourage of med students and fellows and such with him. And I just kind of snuck in on the back of this. I was actually following another physician, Elisa LaBelle, who was more of a specialist in pediatric CRPS patients. Anyway, so I spend the morning and I just kind of blended in. And then we're sitting there at lunchtime and he's going over the cases. And he's asking questions. He's asking questions about which nerve fibers are most likely to create the problem here to his med students. And it was one of those questions where no one answered the question, but I knew the answer. And I knew he didn't know me. I didn't know if I should answer the question. So I answer the question, and he looks at me and he goes, "Who the hell are you?" And I said, "I'm a physical therapist, I'm here." So I walked up to him afterwards, and he goes, "I'm going to send you 2 patients to see how you do with them." He sent me his son and his daughter to treat. Talk about stress. They did well, fortunately, and it kind of put my feet on the path of a very specialized area of treatment. But this isn't exclusively what I treat, but I do a lot of work in this area. And I'm constantly looking for what works, because a lot of what I did not work. And that's a frustrating thing when you hang your hat on how you make people feel. And when you go home and you can't make everybody feel the way you want them to feel, you can't get them better, I took it very personally. It was very challenging. So I'm constantly looking for an area. And the presentation I'm doing today, and if you notice, I adjusted the camera or the projector back down. There's not a lot of words in my presentation. you're going to see pictures, and I'm going to talk to you about the whole idea of this idea of retraining your brain. Retraining your brain, that's kind of a weird concept. So the area that we're looking at right now in physical therapy and in the understanding of the disease process is maybe what we've been doing from a physical therapy perspective isn't the right way to treat these problems. All right? This is a lot of the work based on a group of very, very brilliant neurologists. Most of them are from out of the country. The hotbed in this area right now is actually out of Australia. If you want to write down a name and look up reading or video on YouTube, a brilliant neurophysical therapist, G. Lorimer Moseley, M-O-S-E-L-E-Y. Yeah, G is his first initial. Lorimer, L-O-R-I-M-A-R, M-O-S-E-L-E-Y, G. Lorimer Moseley. Brilliant individual, thoroughly enjoyable to listen to speak. YouTube videos out there, but I'm talking about pain and the idea of pain. Anyway, that's a name that you can hang a lot of confidence in when you're reading about thoughts on this whole process. All right? So what is the historical expert way of treating this disease? What are rehabilitation recommendations? These are the tools that I came out of school with, and they didn't change a whole lot. But I knew right away it wasn't working. How many of you have been frozen, scrubbed, pushed to the point where your pain is just shutting you down? Going from an ice bath to a hot bath. Using a good old distral file if you had upper extremity RSD. Or when we started, we give the patient a scrub brush, put them on their hands and knees, and scrub the floor. That was one of the things that we were told we were to do with patients. And you know what? Sometimes it worked. We filled gallon jugs with water and made patients carry them around. Sometimes it worked. Rarely, though. All right? Lots of interesting trials. We put them in situations, we made them put things up on shelves and stack things and button buttons and tie shoelaces and put their feet in rice buckets, fluidotherapy, hot water, ultrasound. It just didn't work. I was very frustrated. We made them pick up blocks, handle things, figure out what was in their hand. Again, it didn't really work. We kept them busy. It was a nice social atmosphere. They were with other people that understood them. They were with people that were sympathetic to them. Physical therapists, we like to listen. We like to find out how you're feeling. Most of you, when someone asks you how you're feeling, you're just like, you really don't even want to know, right? You don't want to get down that road. And the people asking you usually don't really want to know either, all right? But physical therapists, we want to know. So that was the biggest benefit, was we cared about our patients, and that helped a lot. Arm bikes, et cetera, et cetera. So the whole idea here was we treat the problem from the body up. From the body up. The reality is, when we look at what the evidence right now is, that all might be wrong. In fact, it probably is wrong. So we're going to turn this around, and we're going to actually treat from the head down. All right, from the head down. That's quite a concept, because no one wants to hear the problem is in your head. It's not really in your head, it's in your nervous system. And where's the biggest concentration of nerves? It's in your head. All right? And when you look at Dr. Getson's presentation, especially from a pharmacological basis, as well as from a nutritional basis, we're trying to change the way that the neurotransmitters in your body are distributed and balanced, and hopefully bring this disease under control. But your brain is the area where the neurotransmitters basically are driven from. All right, so can we control the way the brain behaves? Can we use the concepts of exercise, which is gradually increasing the amount of stress on the system, not to the point where you break it down, but you stress it just enough to push it forward to make something change. So the concept of working from the brain down, using the same idea, caught hold and interest. Can we exercise the brain just enough to make it move in the right direction and change things. Novel concept. So we move forward as physical therapists looking at this as neurologists. We can't talk about this without talking about the homunculus, or the homunculi, plural. Now, I heard this term when I was in school. I didn't really know what it meant until, I know what it represented, but I didn't really know what the word means. I didn't look it up. How many of you guys watch The Big Bang Theory? I learned something from The Big Bang Theory. Homunculus equals tiny man. Tiny man. There's a tiny man inside your head. That's a Kinks song, if you guys know the Kinks. Paranoid. Never mind, I won't sing it. Okay, so what is a homunculus? I'm going to stand over here. All right. The homunculus is represented of the somatosensory cortex in your brain. One of those wrinkles is dedicated to a map, sensory-wise, of nerves that are distributed through your body. Areas that are overrepresented, your hands, your feet, your lips and mouth, etc. So the homunculus is drawn in proportion to the way that the nervous system is distributing sensory input from this area. That's homunculus. But you don't just have a sensory homunculus, you have a motor homunculus as well. And they run right by each other. Here's your sensory or somatosensory. Somato meaning body. Sensory, obviously, we know what that is. Cortex from the cortical component of the brain. You have a somatosensory strip. The left side of your brain represents the right side of your body. The right side of your brain represents the left side of your body. You have a motor strip that does the same thing. So the nerves go into the muscles that move your body actually right side by side. And they work together because before you go to move, the somatosensory cortex, which also contains the premotor cortex, activates and sends a motor program to the muscles for them to start moving. They should be discrete, they should be individualized, and they should work together. All right? So what happens when you have spread of pain that is well beyond anything logically explainable by an anatomical structure being injured? This is an actual drawing of one of my patients' pain drawings where they're drawing in the pain. In fact, there's an emotional aspect here. The lines go outside the body. All right? They spread all over the place. So what tends to happen when you have chronic pain long term is you actually start to lose body image. All right? You lose body image. And that's something that the physical therapists and neurologists that were looking at this idea of treating from the head down started to see very commonly throughout this problem. So they said, let's see if we can figure out what's going on inside the brain with patients that have chronic pain syndromes versus those that do not. And recently, in the advent of imaging studies, they've been able to do functional MRIs, which is a combination of an MRI and a PET scan, a PET scan. PET scan actually looks at radioactively labeled glucose and where that glucose is being utilized. So they could put patients in an MRI and a PET scan combined, and they could ask them to do a task, think about doing a task, and see what lights up in their brain, and get an idea of the picture of what's going on. So what does this look like? In a control group, the imagining component, they ask the patient to extend their wrist and bend their wrist or squeeze a ball while they were in the MRI. In the control group, you can see the imagination component, the premotor cortex lights up, plus other experiential memory cortices light up, and the brain is able to go ahead and get ready to move. So they're just thinking about doing the motion, but not actually doing the motion. When they execute the activity, their motor strip lights up and other aspects of the brain lights up. It's very organized. In the CRPS patient, what happens? In the imagining phase, they can't turn it on. They can't figure out how to move in some cases. They lose the ability to even think about movement. They can't plan for movement. And when they try to move, everything lights up. Pain areas light up as well. Even in the imagining phase, they found pain areas lighting up. So patients with CRPS, thinking about moving was painful. But something else happened. They lost organization. They smudged neurons that are associated with pain into their motor cortex and into their premotor cortex. So the idea of moving became painful, and moving itself becomes painful. It's called smudging or disorganization. All right? Your brain physically rewires because of this disease. It changes. Left hand, right hand, just showing this difference. Okay? All right. So what happens when someone goes down the hill? I've got a GoPro camera on my head. I'm getting ready to ski a mogul run right here. That's my daughter down there working her way down. It's pretty steep. I'm going to spend some time thinking about it. I'm pre-planning. I'm thinking about what I'm going to be doing. Now I'm getting ready to go down the hill, and I'm ready to run. All right? If you see an Olympian getting ready to run a slalom race, or a skier getting ready to go off of a jump, or a diver getting ready to jump off the diving board and do a series of maneuvers to go off the diving board, and if you get a chance to watch them in their warm-up, how many of you have noticed them? They'll close their eyes, and they'll run the course, or they'll do the motions in their head before they go to do the activity. It's a very powerful skill, a very powerful tool. There was a study where we looked at individuals to see how strong their little finger was when we added a force dynamometer to see how well we could give them, or how they could give resistance pushing out against a force. Took a group of people, and we had them do nothing. We measured their strength. Another group of people, we showed them an exercise where they put a rubber band around their finger and moved their finger out to the side. We had them do this exercise over the course of 4 weeks. A third group of people, we showed them the exercise, but we didn't let them do the exercise. But instead, the same amount of time that the group of individuals would spend exercising, they had to think about doing the exercise for that same amount of time over and over again. Just do it in their mind. Guess what happened when their strength was looked at 4 weeks later? The group that did nothing didn't change. The group that exercised changed nicely. The group that thought about it gained about 3/4 of the strength of the other group that did the exercise, just by thinking about it. Now, don't think that you're going to get healthy and fit by thinking about it. That's not the message here. The message is your brain and organizing your thoughts has some power to it. All right? Okay. So the first step in understanding if you or a patient of mine has this issue of brain organizational changes going on is to do a test to see if they still have body image organization, right and left organization. And this is what comes from the group out of Australia, the Neuroorthopedic Institute. G. Lorimer Mosley is one of the individuals involved in this, along with others. This is actually a shot from the web page. And I have an app on my phone that allows me to do a test. I can purchase these apps called Recognize off this website, and I do use them in my clinic. I have one for feet, I have one for hands, I have one for shoulders, I have one for low backs. There's also one for necks, where we can actually test to see if my patients have good body image. All right? So I'm going to have you guys you have a piece of paper in front of you. I'm going to give you the test. Are you guys curious how you're going to do? All right, here would be the test. So on my phone, I click into the app, and I have a choice: vanilla hands, context hands, or abstract hands. If I'm doing hands, we'll do it for hands just for the purpose of simplicity. But this could be feet as well. And I would choose vanilla hands, and then what it would do is take me to a screen where I can change the parameters of the test. This is the default screen. You're going to look at 20 images. So take just a second and number 20 numbers where you're going to write an R or an L by that. So write out, if you're so inclined, even those of you that whether you have a disease or not, I want you to go ahead and do the test to see what happens. An R or an L. But just write 1 to 20. Because you're going to look at images of hands, and you're going to have to decide if it's a right or a left hand. All right? This is the way we test for this. This has been done over and over again, And the results are fascinating usually. All right? So the first image you're going to look at, you're going to look at a hand in a position in space, and you're going to determine if it's a right or a left hand that you're looking at. All right? Here we go. This is the first one. I'm going to give you 5 seconds for each one. You're going to write an R or an L by number 1. All right? We give 5 seconds to the image, and the patient clicks on. There's a second image. Is that a right or a left hand? If you don't get it, leave it blank. Third image. Fourth image. This is image number 5. If you didn't get the other ones, leave it blank, but make sure you write down number 5. This should be image number 6. Image number 7. Image number 8, a little tricky. Number 9. Number 10. Number 11. Number 12. Number 13. Number 14. Number 15. Number 16. Number 17. Number 18. This will be 19. And 20. All right. All right, so the nice thing about the app is you just have the page, you just click on it. You can have that, you can download the app yourself actually too. And then it'll score you and give you your score. But if you're curious as to if you got them right, here's your answer key. I'll leave this up for a few minutes and let you guys just look over and just put a little, draw a line through the ones you missed or whatever. What I want you to pay attention to is, does it match to the side of your disability if you see more of them incorrect? All right? There's an equal number of each. There's 10 and 10, so leave it up for a bit. If you can't see it all and you want me to call them out, I will. Would that help? No, not how many you got wrong. We won't know that. You have to figure out how many you got wrong on your own. We won't worry about that at this juncture. But it's just to give you an idea of how accurate were you. What is normal? What is normal? Can I go on to the next slide yet? A few more minutes? If you miss all the ones on one side, that's the side you're already starting to neglect, or it's being wired out of your brain for recognition. It'll usually be on the side of your disease or your symptoms. Well, let me clarify what you're looking at here. That's probably the way it's going to be. All right, so I'm going to give you a chance to just finish your discussions for a second. I'm going to actually show you a test I took on a patient just yesterday. This was a patient that was sent to me because she has a shoulder problem. She had surgery on her shoulder, and the surgeon found no problem at all. Her injury, she's a nurse. She was transferring a patient. The patient yanked on her shoulder or arm. Her diagnosis sent to, not me, I'm the third therapist to see her. Her diagnosis was a shoulder sprain strain. MRI done, showed a little bit of rotator cuff disease. Went to a shoulder surgeon. Shoulder surgeon did surgery and found no problem when they put the scope in her. She comes back to her therapist she was at before, not getting better, and finally ends up in my clinic because the therapist heard about what I was doing and sent the patient to me. So I have a pristine MRI, shoulder surgery, and her rotator cuff and shoulder doesn't work at all. She has pain. If I approach her, before I even go to lay my hand on her shoulder, I'm like, oh, we got CRPS going on here. We've got central sensitization. I like that better. I would start with that at this point. She doesn't have the sensory motor changes. She doesn't have the color changes, but she's just at the tipping point to this problem. I didn't do these tests with her. I started with traditional therapy, but having her understand what we're dealing with. And I said, you know what? Let's talk about your problem. We're going to do a little test here. Here's her score. Guess what shoulder is her bad shoulder? Her left. She was blown away that she couldn't recognize left. Normal is 85%. That's 80 to 85% is normal. She's normal on the right, and she's abnormal on the left. I see this without exception with every patient that I treat and test with CRPS. Yes. Then both numbers will be low. Both numbers will be low. If you have the problem spread, if you reach the point in the disease process where it's spread to everywhere, the whole thing will be off. If I catch it early on, where it's still limited to one side, that will be the side that will be the low score. It's called a recognize. RECOGNISE. It's spelled in Australianese, so there's no Z in it. RECOGNISE, recognize. Okay? So I said, let's start treating you. So how do we treat this, or how do we retrain the brain? Yes?
Can you explain again how that, can you just real quick explain again how that works? How that, the correlation between how, the way that you guess and what side it is?
What happens is, what we find is happening with patients that have amputations, CVAs, and a neurological disorder where their neural system is shutting down on one side. You will start to shut that area off mentally. You'll start to neglect it. Your brain will actually start to shut it off. If it's constantly being barraged by pain, let me use the example of this. If you're surrounded by a bunch of kids and one of them is constantly annoying you, what's your first thought? Your brain is actually doing that probably with this disease. Your brain is starting to wall off or start to push off that constant barrage of pain. And what happens is you start to lose somato or body recognition of that area. All right? All right. Tough concept, but that seems to be what we're seeing here. So how do we retrain this? The evidence right now, and from the studies that we've seen, and on systematic reviews of the literature, this is the one area of treatment in physical therapy right now that shows any promise on constant study. So we've broken the training process down to actually 3 formal phases, but there's a more recent study that says maybe we should be doing 4 phases. So I'm going to give you the 4 phases of training. All right, the first training area is laterality training. I need to train my patients to be able to recognize right and left. It is so important. All right? How do I do that? I sit them down, I give them magazines, or they get their own magazines, and they set a timer. Right now we go anywhere from 10 minutes, 5 minutes, or 3 minutes, depending upon the patient's tolerance. If I told you to go out and run for 10 minutes and your ability to run is only 2 minutes, the last 8 minutes of that run is going to be damaging you. So it's the same thing with this. If in doing the exercises your pain starts to come up, we don't push you beyond that point. In fact, the rule in my clinic is no pain, no pain. Not no pain, no gain. Do you understand that? Yes. How many of you have been through the no pain, no gain treatments? It doesn't work. All I do if I give you an activity that's painful, I wire pain back into your problem. I'm trying to wire it out. All right? So you would look at a magazine or an image, and you'd write an R and an L on the right hand, right shoulder, right foot, left foot. My patient that had the 57%, I gave her a magazine. I said, here's a timer for 10 minutes. I go, see what you can do. She was blown away. She goes, I could not recognize the left shoulders. I could see the right away. She was blown away by it. She hadn't seen this before. No one had talked to her about this before. All right? So that's the first phase. That what we're finding is you have to do this every day. You have to do it 3 to 5 times a day. When I first started, we thought it was once a day. But it has to be 3 to 5 times a day, and it has to be at a level that you can tolerate. This is a medicine. It's a dosage. If you underdose, no change will happen. If you're non-compliant, no change will happen. If you overdose, you'll be in more pain. So the patient has to find their level of tolerance, their comfort zone. All right? And then they stick with that. They stay with that. And we can boost it up a bit. We can expand it. We can start with maybe 2 minutes, work up to 3 minutes, 5 minutes, 10-minute sessions, 3 to 4 times a day. We're literally trying to change the neurology of your brain and rewire the nervous system. We're laying down new nerves, nerves that recognize the injured area. A minimum of 2 weeks is the length of time the patients have to do this, a minimum of 2 weeks. And I have them continue on as booster shots, maybe every other day.
The correlation between people who say have pain in one hand and their lack of being able to get 100% or 50%.
The studies right now show about 80 to 90% correlation. Not necessarily. The lady that I mentioned to you already, we're actually seeing those with patients that don't have CRPS, you just have pain. They have a sore back. They can't recognize the side of their back with the pain on it as well as the other side. Your brain starts to do this as soon as you start to have pain. Just like that annoying child or individual, you want to start to kind of like ignore them a little bit. You know, it might not, I wouldn't espouse that, but it's a process your brain goes through as a preservation mechanism, probably. So if you guys, I'm going to leave time for questions at the end. Are you guys okay with that? Because there's a lot more to go here. All right. Phase 2. You have to do mental manipulation of your extremity. You have to imagine your hand assuming the positions that you're seeing. You have to do the same rule that I showed there before I ran that mogul field on my skis. I imagined making those turns. I imaged it. I imaged the thing happening. All right? So we put the patient in front of a mirror. This is important. This is a new component of this. And we give them pictures of images of hands, or we have images on a computer screen. And they look at the image. They don't move anything. They just look at it, and they imagine their well hand, not their injured hand. They just look at the image. All right? So what you're seeing here is a reflected image of the well hand. The injured hand is behind the mirror. They can't see that because the mirror's high enough that they can't look over the edge of the mirror. And it is laying still. Most therapists that do mirror therapy skip all the right steps. They go right to put the hand behind the mirror, and they start moving it around, and the patient's like, they get worse, and they get worse. It has to be done in a gradual fashion, all right? So the first actual phase after you've done the right and left training for 2 weeks, after 2 weeks of that, we put you behind the mirror, and you just look at the images. And you see your well hand reflected in the mirror looking at images. That's all you do. We set a timer for 5 to 10 minutes, and that's what the patient does. They go home. They set up a mirror themselves at home. They do this at home 3 to 5 times a day, just looking at images for 2 weeks, minimum of 2 weeks. We've got to get the brain adapted to the process, all right? Phase 3, the unaffected hand, the uninjured hand, is going to move now, all right? So I'm going to look at the image and move the unaffected hand into that position and out of that position repeatedly, or have it hold the position. It could be either one. But what my brain is now going to see is my injured hand moving when it isn't. My brain sees my injured hand moving, all right, when it isn't moving. So the uninjured hand is moving, the injured hand isn't, but my eyes see my injured hand as a moving entity. If that creates pain, I stop the treatment. I go back to the last phase that was non-painful. Just like if I was having you lift 15 pounds and it didn't hurt, I said, it's time to lift 25 pounds. You go, I can't do it, it's too much. We go back to 15 pounds. And you go 2 more weeks at the level that you're comfortable at. Yes? I'll get to it. Okay. I probably get to all your questions, and if I don't, I'm going to leave plenty of time. All right? Phase 4, what we do now is we actually have the injured hand match. But you don't look at your injured hand, you look at your reflected well hand in the mirror. All right? So it would look like this. Oh, there's a video working there. That's the well hand moving, and you're seeing the injured hand move without pain. Yes?
My hands are not affected, my foot is. So
We do it with your feet too. It doesn't matter what body part. Doesn't matter.
I tried the mirror there.
You probably didn't do it right. Or they skipped some steps. Or they pushed you too hard. Or they weren't consistent. Or you didn't do did you look at the magazines for 2 weeks? Woman's Day, Handyman, whatever you have around the house. So, again, let me get back to the questions later. I'll go through all this. All right? All right. Oh, it's time for questions. Your question. What if it's your foot? What if it's your knee? What if it's your shoulder? I would still use the same concept, but have you look at shoulder pictures, or look at knee pictures or foot pictures, and have them in different positions to see what you're doing with what's going on there.
Fine, just repeat the question if someone...
Okay, the question is, what if it's a foot? What if it's something else? We use images of those, and we reflect them as well in a way where you exercise the same way. Anyway, thank you very much. It's a true pleasure.